Welcome everybody. We are back today with Michelle Pensa Branco and Jodine Chase from Safely Fed Canada. Michelle has a background in public health and is an IBCLC, and Jodine Chase has a background in media and communications. And we are going to follow up on our updates on COVID-19 from where we left off last time. So I have welcome both of you.
Thank you.
I have a question for each of you, and one will be a follow-up question that has come from the previous interview that we did last week. And so the first question that I have for you will be to you, Jodine. In the last interview, I asked you what was one of the key messages for families, and you talked about targeting different messages depending on the circumstances. When you said that it's not a good idea for somebody who is not breastfeeding, that they should be breastfeeding, there was some feedback in the community about this comment. So I'm thinking people may have thought that you were saying that we shouldn't be advising breastfeeding at this time. Would you like to clarify what you actually meant by this and add anything else?
Yes, thank you, Carole. It's very interesting, actually. It sort of underscored the point that I was trying to make and clearly didn't make well, in that it's really important for us to be careful in our communications and in our messaging, and to make sure that the message that we're delivering to a particular audience is targeted for that audience. And so what some people heard was that I was suggesting that we shouldn't tell people who aren't breastfeeding about the importance of breastfeeding. And I did say that. What I wanted to get across was that because that's not going to be effective. And so we need to find effective ways to communicate to different groups of people. So if you have someone who's pregnant and is due to deliver and is about to go into the hospital, that is a critical thing that they need to hear about how important it is to breastfeed right now during this crisis, even if they weren't planning to breastfeed. We have a large number of people, especially in Western parts of the world, who aren't breastfeeding aren't able to breastfeed even to their own ideas of how long they wanted to breastfeed, and certainly aren't breastfeeding as long as the global guidance, which is, of course, exclusive through to 6 months, and then to continue breastfeeding with complementary foods through to the end of second year and beyond. So I don't know if you need to tell our audience what the guidance is, but I guess the point is that when you have someone who is not breastfeeding for whatever reason, and the message they hear is, you need to breastfeed, you should be breastfeeding for the health of your baby right now in this crisis, if they don't feel that they can change anything about their circumstance, that message is not going to resonate for them. In fact, that message will probably trigger some emotional reaction or response that will upset or concern them further. So this is a particular group of people that we really want to be intentional with when we're speaking to this group. But we also can't withhold information from them. There's no point in saying to someone who's not breastfeeding, oh, everything will be fine. Rather, what they should hear is what steps they might take to improve the health of their newborn or their infants. And they do need to hear that their lactation, the actual process of lactation, is quite robust for most women. Most people, I think, are afraid to talk about relactation, for example, and we don't have good resources for relactation. We haven't done a good job of communicating around these issues in the past, and so it's certainly, in the midst of a crisis, it's not an easy time to suddenly get better at how we communicate, but I think we're going to have to. I think that we're doing a disservice to families if we don't talk to them specifically about what they can do now to improve their health of their babies, and if they're interested in relactating or improving their lactation if they're only breastfeeding a small amount, we need to be ready to support them with really good guidance and assistance. So I don't know if that's going to clarify or if that's going to muddy the waters further, but I just thought it was such an interesting exercise to realize that what I thought was a clear message didn't come through clearly out the other side, and it helps all of us to remember that what people hear is not what we necessarily intend for them to hear.
Yeah. Thank you so much, Jodine. I found that much clearer in general, and hopefully our audience will as well. So, I think the message has always been that we support breastfeeding in all circumstances, and the ability to support families in general is also really important, because no matter what, if you can't change something, you can't feel excluded either.
Well,
So I think, yeah.
Or if you think you can't change something. And
Yes.
I think that we've been doing families a disservice. We probably should have been communicating about relactation all along, all the way across the board. So many people still think that once you stop breastfeeding, that's it, your milk is dried up, and and you can't do it again. And we haven't done much to correct that advice.
Yeah. So I think that's a good, finding new resources about relactation is going to be probably a really important stepping stone from now on. And I think we need to be able to provide that information to the families, and in reasonable ways that is easy to understand. So I think that's great. Thank you so much, Jodine. I really appreciate it. Now I have a question for a follow-up question also for Michelle. And at the last interview, we basically talked a bit about the guidance and the rollout of this guidance. And we are seeing some confusion with different information from different organizations. Guidelines are related to COVID-19 and breastfeeding or birthing or skin to skin. How would you like to address this?
Well, I mean, I think as clinicians, if you think about how often you hear from parents, we hear something different from every person we talk to. We're experiencing a little bit of that ourselves right now. So this is perhaps a good experience for us as clinicians to think about that common refrain that we hear from parents, which is, in a time of some intensity and some stress, the information that we're receiving is not always heard and stored in the way that it's intended. And I think differences in guidance can come from different places. So sometimes it's a matter of looking at guidance that was issued early on, particularly in something that's moving so quickly and that's so unusual and unique in our modern memory. So things that were early guidance that was issued when some aspects were less clear may appear to contradict guidance that's issued later. So it's really important to really keep an eye on the date and whether and when revisions are being made. So organizations are revising and making changes as soon as they possibly can, but there's going to be some gap between those. And sometimes it's a context-specific question. So you mentioned relactation. Relactation is something that in the humanitarian context is discussed quite a lot, and there's lots of expertise in that area in the humanitarian context. In our world, while most of us as IBCLCs know what relactation is, that restarting of breastfeeding after we've stopped, it's really considered something that's quite difficult and quite unlikely to work. So what's considered possible in one place might not be considered possible in another, and so we have a different lens by which we interpret the circumstances. And then there are sometimes legitimately different views on issues. So there are some pieces of the guidance that are pretty strongly universal, but there are other pieces where people have different scientific opinions on what should be weighted in which way. I will say in general, though, that the guidance that's been relevant to Canada that I've seen so far doesn't have major contradictions in it. So we tend to have a pretty generally consistent picture across the board from the WHO, UNICEF, the Public Health Agency of Canada, as well as what I've seen of the provincial level responses around breastfeeding and birthing. What is seeming to happen, and what often does happen in emergencies, is the applications on the ground at the field level, at institutions and facility level, isn't always consistent. And possibly that's because those decisions are being made out of sync with when the guidance is being issued. So people are making decisions based on one set of information without seeing the whole picture of the guidance. And those policies go forward because we can't be changing our policies every 12 hours on every topic. And sometimes they're based on factors that the guidance just didn't necessarily account for. So facilities have realities and circumstances and contexts that aren't entirely captured within the general guidance and need to be interpreted at the facility level. And some of the things that we're seeing, for example, are reports of, and in fact, statements around not allowing labor support people to accompany women through their labor, and when they are allowed to accompany women through their labor, having them go home very shortly after the birth, which is something that can really leave new parents quite unsupported and create real difficulties for them in getting breastfeeding and bonding off to a good start. Other things that we're hearing reports around is disinfecting women before doing skin to skin after birth, which is something that we just posted an article on our website from Louise Dumas, who's a Canadian researcher around the lack of evidence for that practice and the potential harm that it could do. But it's something that we're hearing from that's happening in hospitals sporadically across the country. Or even not having proper protocols in place to handle expressed milk from women who are either positive or presumed positive. So if they're expressing their milk because their baby is in the NICU or because they're in isolation and not with their baby, what kind of protocols are in place? And those are really varying from place to place, and in some places they haven't been rolled out fully. So we are seeing at the facility level some of those questions and those concerns, but I would say that in general, the high level guidance is actually, it's pretty consistent, and it's pretty consistently framed around not doing harm. So ensuring that physiological birth, the normal baby mother transition post-birth, and then the move to exclusive breastfeeding and return home to be nurtured in the home environment as soon as possible are all pretty well established in the guidance that we have.
Okay, that's really great, Michelle. I really appreciate it. So back to my final question: 2 take-home messages you'd like our community to receive today. Any ideas you'd like to pass on?
So I think the one key message that we would like to have families who are preparing to birth is really to focus on what they can do to make sure they have all of the supports in place in advance, and for when they're going to be coming home, to plan to be at home earlier than you might normally be after you birth in a facility. Plan to breastfeed, even if you don't plan to breastfeed long term, plan to breastfeed now. And also, I think we want families to figure out how to reach out to support in different ways. So if you don't have someone who's going to be there with you, what can you do to bring your support people into the room with you, using technology just the same kind of technology that we're using now. The more planning that people can do ahead of time to support their breastfeeding, the better they're going to be once they're through and out the other side of that birth.
Thanks, Jodine. Michelle?
So Jodine's done a good job of telling us what we'd like families to know, and I think from the perspective of the healthcare system, what I'd like to remind the healthcare system is how much families are relying on the healthcare system in this period of their lives, and while we pivot our attention obviously and correctly towards pandemic preparedness and response, that babies are going to continue to be born. We have lots of the skills and protocols and processes in place, and but we need to apply them, and we need to apply them in a calm, evidence-based, considered manner. And once we have those solutions in place, share the best practices that you're doing openly with your colleagues, so that not every one of us has to redo the same thing every time. And we'll try and do that. That's one of our mandates, is to share those best practices and share those successes. But it's really hard when everyone's focus is shifted in one direction, to remember that those babies are going to continue being born, and they're continuing to breastfeed through their first 6 months, continuing to start solids, continuing to do all of those things. So that's what I would really encourage people to do, is to make a considered plan, and once you've got a considered plan that's working well, to share it with your colleagues so that they can benefit from it too.
Thank you again both so much. It's always a pleasure to talk with you, and hopefully we'll be able to do this again, and keep everyone updated in our field with what's going on. Thanks again, and have a great afternoon, both of you.
Thank
Bye-bye.
you.